Welcome to the Rad-On Smart Review CNS Cancer Series.
Great to be here.
Today we're tackling, well, a really dynamic and sometimes perplexing area in Rad-On SAM right now. It's about sequencing stereotactic radiosurgery, SRS, with immunotherapy and targeted therapy for brain mets.
Yeah, it's a puzzle, isn't it? And one that seems to change almost, constantly.
Absolutely. These new systemic therapies, some have incredible activity inside the brain.
You really do. It's completely rewritten the playbook.
So that old radiation first idea.
Yeah, that's often too simple now. Sometimes it's even, the wrong call.
So our goal for this session is really to give you a practical guide, sort of a modern take on navigating this new reality.
Exactly. We want to talk about when it actually makes sense to defer radiation.
Okay.
Compare the CNS efficacy, how well different systemic drugs work in the brain.
Right.
And this is critical, really detail the safety aspects, the toxicity risks when you combine SRS with these potent new agents.
Okay, to make this really concrete, let's think about three hypothetical patients. The kind who could walk into your clinic any day.
Good idea.
Each one has a bit of a sequencing dilemma, but the basic question is the same. Do we treat with SRS now, or do we let the systemic therapy work first?
That's the million-dollar question, right? Keeps us on our toes.
It really does.
And honestly, the answer, it really depends. Depends on the histology, the specific systemic drug available, the whole clinical picture,
So it's not one size fits all.
Not at all. We can kind of break it down into maybe three main philosophies or approaches that guide these decisions.
All right, let's start with patient A. Imagine a 58-year-old, newly diagnosed EGFR mutant non-small cell lung cancer.
Okay.
They've got 3 brain mets, asymptomatic, just 5 millimeters each.
Yeah.
Small, quiet. What jumps out at you there?
Well, for patient A, my first thought often leans towards a systemic first approach, which we'll get into.
Okay.
But let's quickly paint the picture for the others too. Patient B, 45-year-old, metastatic melanoma. 5 asymptomatic brain mets, about 1 centimeter each this time, so a bit bigger, but still no symptom.
Okay, melanoma, 5 mets, and patient C.
Patient C is 52, HER2 positive breast cancer, single brain met, 1.5 centimeters. And she's about to start the antibody drug conjugate, trastuzumab deruxtecan.
Okay. That one immediately raises some red flags, doesn't it?
Yeah.
Why is that specific drug combination a concern?
You're right to flag that one. Patient C, with that particular ADC, needs extra caution. We'll definitely circle back to why.
Okay.
But first, let's dive into those 3 philosophies, starting with number 1, systemic therapy first. Deferring radiation.
Right, this idea of holding off on radiation. It feels relatively new, but it's becoming much more common. When can we actually feel confident doing that, holding SRS back up front?
We usually reserve this for systemic agents that have, a proven really high chance of controlling the disease inside the brain.
Okay.
And patient A, our EGFR mutant lung cancer case, that's like the textbook example for this approach.
Because of the specific drug.
Exactly. The 3rd-gen TKI, osimertinib, it just has outstanding CNS penetration and efficacy, really gets into the brain and works.
Okay, outstanding is a strong word. What kind of numbers are we talking about? What do the trials show for CNS response?
We're talking serious numbers. Trials like FLORA and RRA3 showed CNS response rates around 66 to 70% in patients with measurable brain mets.
66 to 70%. Why?
And it's not just shrinking mets. The Bloom study looked at leptomeningeal disease, which is notoriously tough.
Right.
And it showed an overall response rate of 62% there, too. That's just profound activity within the CNS.
Okay, with data like that, deferring upfront SRS for those little 5 millimeter asymptomatic lesions, it suddenly makes a lot of sense.
It does.
What's the core thinking there? Just keeping radiation in your back pocket.
Pretty much. You've got such a high likelihood of shrinking those brain mets with the drug alone. You buy time, you hold radiation in reserve, avoid potential side effects until you really need it, maybe for progression down the line.
Makes sense.
And this same logic, this approach, it also applies really well to ALK-positive non-small cell lung cancer.
Okay.
Especially when you're using potent inhibitors like alectinib or lorlatinib. Their CNS response rates can push close to 80%.
80%?
Yeah. It's really been a game changer for these specific patient groups.
Right, let's flip the coin. Philosophy number 2, radiation first, the traditional way.
Right. Standard practice for years. Secure that intracranial control up front.
When does that approach still make the most sense today?
Well, while it's maybe less of a universal rule now, it's definitely still valid. Crucial even if the patient has symptoms from their brain mets.
Okay, symptoms are key.
Absolutely.
Oh.
Or if the systemic therapy you have available just doesn't have great or maybe uncertain CNS response rates.
Right.
You just don't want to gamble if someone's symptomatic or if you're not confident the drug will work well in the brain.
Can you give us an example, a scenario where radiation first is clearly the kind of safer bet?
Sure. A good example might be metastatic renal cell carcinoma.
Okay, RCC.
Yeah. Agents like cabozantinib, they do have some CNS activity, but the response rates just aren't in the same league as something like osimertinib for EGFR lung cancer.
Got it. Not as reliable.
Exactly. So in a case like that, hitting those known brain mets with SRS first is often the safest, most reliable path to getting that intracranial control sorted out.
That makes sense. But, speaking of EGFR lung cancer, I seem to remember some data challenging that systemic first idea. Even there, was there a Yale study?
Ah, yes. You're probably thinking of the Magnuson paper from 2017.
That's the one. What did it find? And how do you sort of square that with the current practice?
That's a really important point. It was a retrospective study, looked at EGFR mutant non-small cell lung cancer patients, and it actually found that patients who got upfront SRS followed by a TKI seemed to have better overall survival compared to those who got the TKI first.
Better survival with radiation first. So how do we reconcile that?
Well, it highlights that this is still an area of debate, right? These aren't always simple black and white decisions. We're constantly balancing immediate intracranial control, which radiation gives you quickly, with long-term systemic control and, of course, toxicity.
Okay.
So I think for many clinicians with small asymptomatic lesions, the TKI first approach is often still favored because osimertinib works so well, and you want to defer radiation if possible.
Mm-hmm.
But that Yale data serves as a good reminder that securing that local control early might offer a long-term survival benefit for some patients. It really comes down to a personalized risk assessment.
That's a great way to put it. Okay, let's move to the third philosophy, concurrent therapy, doing both around the same time.
Right. This one can feel a bit like high risk, high reward sometimes, especially combining SRS with immunotherapy.
Yeah, there's this fascinating idea about biological synergy there, right?
Exactly. The preclinical data is really intriguing. It suggests SRS can act like an in situ vaccine.
An in situ vaccine, how does that work?
So that high-focused dose of radiation basically blasts tumor cells open, releases a flood of tumor antigens. And that release seems to prime the immune system, wakes it up, makes it more responsive to the checkpoint inhibitors.
So the local radiation treatment might boost the systemic immune effect.
That's the theory. Potentially turning a local zap into a systemic immune boost.
And are we seeing evidence for this in the clinic? Does it actually play out?
We are starting to see signals, yeah.
Yeah.
There was a retrospective study from Johns Hopkins, for example.
What did that show?
It found that giving SRS and immunotherapy concurrently, or very close together, was associated with improved overall survival.
Improved survival, wow.
And also a lower rate of new brain metastases appearing later compared to giving them non-concurrently. And importantly, it didn't seem to come with a significant increase in radiation necrosis in that study.
Okay, so better outcomes without more toxicity in that analysis.
Right. And that kind of data has certainly encouraged the common practice now of giving SRS and checkpoint inhibitors, pretty close together concurrently or with minimal delay.
This brings us back to patient B, the one with melanoma. What are the CNS response rates we should know for immunotherapy in melanoma? Single agent versus the combination.
Good question. For melanoma, if you use a single agent checkpoint inhibitor like pembrolizumab, the CNS response rate is around 25%, which is, okay, decent, but not spectacular.
25%, okay.
But the combination ipilimumab plus nivolumab, that's much more effective in the brain.
How much more effective?
The Checkmate 204 trial showed a CNS response rate of about 55% for Opinivo.
55%, that's more than double the single agent rate.
Exactly. It's a really significant jump in intracranial control for those patients.
That's a huge difference.
Okay.
Okay, but now, while we're on combinations, we absolutely have to go back to patient C.
Right. The HER2 positive breast cancer patient starting trastuzumab deruxtecan, TDXD.
Yes. You flagged this earlier. This is where we need a big flashing warning sign, right? concurrent SRS with certain ADCs.
Absolutely critical safety warning here. This is emerging data, but it's consistent and concerning.
What's the specific concern with ADCs like TDXD and concurrent SRS?
There appears to be a significantly heightened risk of symptomatic radiation necrosis when SRS is given concurrently or very close in time with certain ADCs, and trastuzumab deruxtecan is kind of the poster child for this concern right now.
Symptomatic radiation necrosis, so serious brain swelling and damage.
Yes. Potentially very serious. The exact why isn't fully worked out yet. Maybe it's increased drug delivery to the irradiated area, maybe enhanced inflammation.
But the bottom line is the combination seems to increase the risk of bad tissue damage.
That's the bottom line. It's a combination you really want to approach with extreme caution and ideally avoid giving concurrently if you can.
So for patients like patient C needing both SRS and TDXD,
Yeah.
what's the recommendation? What's the safest way?
Based on what we're learning, the safest approach is to separate the treatments, create space between them.
Separate them how?
Either complete the course of SRS before the patient starts the ADC, or if they're already on the ADC, hold the drug for a period around the time of SRS. We don't have exact optimal windows defined yet, but creating that separation seems key.
So deliberate sequencing, putting time between the two treatments.
Precisely. That separation appears crucial to mitigate that heightened risk of severe rad necrosis. Timing is absolutely critical here.
Okay, that is a hugely important safety point. Let's pause here and maybe distill some of these key takeaways. Time for our clinical pearls.
Sounds good. Pearl number 1. For those asymptomatic small brain mets in EGFR mutant or ALK positive lung cancer,
Yes.
deferring upfront radiation and going with a potent TKI first, like osimertinib or alectinib, is a standard justifiable strategy.
Right, justified by those really high CNS response rates, over 65, even up to 80%.
Exactly. Pearl number 2. For melanoma brain mets, remember those immunotherapy numbers? Single agent checkpoint inhibitors around 25% CNS response. But the combination, ipi/nivo, jumps way up to about 55%. Big difference.
That combination really changes the outlook for intracranial disease. Got it.
Pearl 3. Concurrent SRS and immunotherapy, generally speaking with checkpoint inhibitors, is common practice. It might even be synergistic, based on data like the Hopkins study.
Okay, potentially beneficial.
But, and this is a big but extreme caution is needed with antibody drug conjugates, especially trastuzumab deruxtecan, because of that heightened rad necrosis risk.
Right. IO combo, okay, ADC combo danger zone.
That's a good way to summarize the current thinking. And that leads to Pearl 4. If you have a patient needing both SRS and a higher risk systemic agent like an ADC, the safest plan involves explicitly separating those treatments in time. Build in a gap. Prioritize that separation for safety.
Excellent pearls. Okay, let's put some of this to the test. Time for our board blitz. You ready?
Let's do it. Question 1 for you. According to the CheckMate 204 trial, what was the approximate overall intracranial response rate for melanoma brain mets treated with the combination of ipilimumab and nivolumab? Was it A, 26%, B, 35%, C, 57%, or D, 78%?
Okay, CheckMate 204, ipi/nivo. We just talked about this. It was significantly higher than single agent. I'm going with C, 57%.
That is correct. C, 57%. The CheckMate 204 trial really highlighted that impressive intracranial efficacy for the combination. Okay, question 2.
Right.
According to that retrospective analysis from Yale on EGFR mutant non-small cell lung cancer patients, how did the strategy of deferring radiation and using upfront TKI therapy compare to using upfront SRS for brain metastases? A, upfront TKI was associated with superior overall survival. B, upfront TKI was associated with inferior overall survival. C, both strategies resulted in equivalent overall survival. Or D, upfront TKI led to better distant brain control.
Ah, the Yale study. That was the one that seemed counterintuitive, right? It found, starting with the TKI was worse for survival. So B, inferior overall survival.
That's right. The answer is B. The Yale retrospective study found that initiating TKI therapy first and deferring radiation was associated with inferior overall survival compared to strategies that included upfront radiation in their analysis. Definitely food for thought.
It really is.
Okay, last one.
Last one. Question 3. For a patient getting SRS for brain mets, what's the clinical implication of the findings from that Johns Hopkins retrospective study on the timing of immunotherapy? A, hold immunotherapy for at least 4 weeks after SRS. B, concurrent administration of immunotherapy and SRS may improve survival. C, timing relative to SRS has no impact. Or D, concurrent IO significantly increases rad necrosis risk.
Okay, the Hopkins study. That was the one suggesting synergy, right? Better survival and fewer new Mets with concurrent treatment without more necrosis in their data. So
Right.
B, concurrent admin may improve survival. Exactly. B is the correct answer. The Hopkins retrospective data suggested concurrent administration was associated with improved overall survival and fewer new brain mets, without a corresponding increase in rad necrosis in their cohort. Reinforces that potential synergistic effect.
Great questions. So wrapping this all up, what's the big picture message here? It feels like the main point is that the old one-size-fits-all radiation-first rule for brain mets is definitely history.
Absolutely. It's history. We've seen how these powerful new systemic agents, especially targeted therapies like osimertinib, can often take the lead, particularly for smaller asymptomatic lesions. You can potentially spare patients upfront radiation.
Right. But we also learned that radiation, SRS specifically, still has a crucial role, especially for symptomatic patients, or when the systemic drugs aren't as reliable in the brain. And that Yale study reminds us early local control might still matter for survival in some cases.
Precisely. And perhaps the most critical takeaway today is understanding that delicate balance when combining therapies. The potential synergy with immunotherapy is exciting. But the very real danger with concurrent ADCs like TDXD means timing isn't just important, it's absolutely paramount for patient safety. You have to separate those treatments.
It's definitely a complex landscape. Challenging, but also, incredibly important to get right for our patients. Staying up to date on these sequencing nuances is just vital.
It really is. And as we look forward, systemic therapies are only going to get better, more diverse. It constantly challenges us to rethink what optimal sequencing means.
It makes you wonder, doesn't it? What do these complex, personalized decisions really mean for the future of oncology care? How might things like, say, AI help us navigate this intricate dance between systemic treatment and localized precision even better down the road? Lots to think about.
Indeed. Thanks for tuning into the Rad-On Smart Review CNS Cancer series.
Yeah, thanks, everyone. Remember, you can get show notes and complete practice oral boards over at radonsmartlearn.com.
And definitely subscribe to Rad-On Smart Review so you don't miss our next session.
Thanks for listening.